right, thank you for being here. Thank you for inviting us. Pleasure. My name is Lukasz Mazur. I'm an assistant professor at Radiation Oncology School of Medicine. And I'm the director of the Division of Healthcare Engineering that has been formed over the last few years to do work on quality and safety in healthcare. With me, I just want to introduce, we have Dr. Prithima Reddy-Mosaly. She will be also a presenter today. She's our expert on physiological data in the lab, and she's a human factors engineer. And Greg Trachton has been with UNC for over 25 years, a computer programmer and inventor really, and helping us on a lot of projects with the skill set that he's had. We can rapidly do a lot of these innovations and try to test them. So three of us will kind of give a few talks. Really the theme for today is going to be this idea about workload and performance, right, within the electronic health records. Like the clinicians are interacting with health IT. So we're going to be talking about that. Just to give you a sense of our division, you know, there's three of us here, but the division is larger. We have folks, as you can see them on the picture, we have some quality coaches and safety. So when we have innovations and they are going to have to be put into practice, you know, people that have been trained on being in the implementation in the field, Kendra, Allison, Kinley, you know, there's a few folks that can less, Robert, and so those guys are out there really running around different locations, implementing this innovation so we can put things into practice as rapidly as possible. So it's really innovative. Innovative things have been created with a vision from Dr. Larry Marks from Radiation Oncology. He had this vision for safety, quality, a physician who has a passion for this work, and we are really grateful to have this opportunity. Just kind of a couple acknowledgments and disclaimers. You know, the work that we're presenting has been originally funded by Center for Health Innovation here, so it was a funding provided from the school, and since then we used this preliminary funding and got a couple EHR-related grants, R21, R18, to kind of continue, and we are finishing that work. And as you can see in the disclaimer, you know, we are presenting our work, and this is not, and doesn't necessarily represent these organizations. So agenda for today. I'll provide background information, motivation for the work. So I'll try to stage stage why we're here, what we're learning, and then Prithima will come in and she will actually run through a few papers that we send out, that we've published, and she'll walk through some of these studies and results that we do in the lab. And then from the practical standpoint, if it talks about workload performance, Greg will present one of his most I think really great recent projects on creating an electronic checklist that is supposed to reduce workload and increase human performance. So he will share with this, and then we'll have kind of a larger Q&A. And if time allows, I will kind of mention later on some of the other innovative work we do on simulation-based training within the EHR and neurofeedback, things that we actually engaged as well. Okay, so let's kind of talk, you know, the motivation for the work. This table will show you kind of a snapshot, you know, done a few months back about measuring workload, right? Mental workload. So if you look at different industries like aviation, transportation, power plants, you know, high reliability, and people that invested a lot of research time and money into creating usability, that's great. You know, you all drive cars, and there's a reason why things are in a certain place, and they know you're going to be on the phone, and you know you're going to text from time to time. So they're really thinking about all the angles and trying to make sure that all the buttons and everything works. So if you can look at how much papers have been published on subjective measurements of workload, you know, there's a column you can see, you know, over 2,000 papers in aviation, and then more physiological measures. Again, comparing to healthcare, you know, we kind of behind the scenes, we could probably do more and understand more of these concepts. So that's what our group does. We kind of glue ourselves to this concept of workload performance, and then we try to go and understand this by having quantifications moving forward, right? So this is a recent report that just came out in March of 2017, and this is Emergency Care Research Institute, so really a valid organization out there from California, and this report tells us that #1 patient safety issue currently is information management in electronic health records. So it used to be, you know, infections, falls, you know, different things, but seems like what claimed to the top right now is that, yes, as we're switching this world from paper to electronic, we're really seeing that how we put the data in, right, how we interact with all all this health IT, and then how we communicate over this has changed, and that's where these human errors occur, and one to another leads to patient harm, right? So this has been just recently reported. So let's kind of maybe talk. So yes, health EHRs, they definitely have tremendous potential to reduce costs and improve quality. So we fully agree. We are not here speaking that let's not use them. That's not the purpose. However, if they are poorly designed, right? Now we're going to talk, and Prithima will talk about it. What about how much task demands are they requiring on the physicians? Don Spencer, who's kind of in charge of the EHR, came to our department few weeks back, and he put the first graph on his talk, and he shows a 2 in the morning spike of physician engaging in Epic in baskets. 2 in the morning spike, just to complete their email, right? That's their results. And one thing he said, his goal in the next few years is to reduce that spike. He doesn't want physicians to go home and wake up at 2 in the morning and keep working, because they come to work tired, they're frustrated, and the cycle begins, right? Kind of over. Errors happen. So we got, and I think a lot of EHRs fighting for the market share have pushed a lot of this out there, and now they're starting to pay more attention about the design and what can be done to improve performance. Give you this paper. We're going to talk about clicks, and we're going to talk about these things. So this paper was published and says that per hour, right, people seeing about 2.4 patients. So in that day, they require 400 mouse clicks in EHRs, right, during the 10-hour shift. So think about 4,000 mouse clicks in 10 hours, and assuming that you're not going to make an error. You're always going to have a precise click on the right box from the drop-down menu, or 2 little boxes next to each other. You're always going to have it right. 4,000 clicks a day. How comfortable we feel about that, right? It's a lot of clicking, a lot of interactions with these systems. Unfortunately, what we are learning from the studies, that a lot of those mistakes, that bad click, ends up in patient harm and in the bad patient harm, right? And then we have a cost of malpractice, insurance costs for these physicians, and you can see how interestingly speaking, 20% of the cost in healthcare is associated with the insurance that physicians are paying, because they have to protect themselves. 20% of the healthcare cost is just right there. Potentially, there are things to be done there. This is an issue. And then the next layer is workflow and communications, right? So now in a hospital, yes, you have a usability when you're interacting, but then you're setting up all these workflows and policies. So now that's 24%, right? And lastly, you can see that, yes, we write the policies and procedures, so maybe some of them are not correct, but again, it's less. So the biggest bang for the buck seems like, for us, if we could do something to create better environments for people so they can perform well, yeah, we can go and train them and remind them as much as we can, but perhaps we can kind of go to this other 2 Swiss layers of the Swiss cheese model that I like, right? So those holes don't align and the harm doesn't happen. We could do this on the usability and on the workflow and kind of communication perspective. That's maybe where we can do some good work.
Lukasz, are you okay if we take some pictures of some of these slides?
Please. Yeah, and we're going to be sending the PDFs of you guys
Great.
these slides, so you have that as well. So another way to look at it, let's look what exactly. So this is real data from one of the hospitals. I'm not going to share which one, and they are coming up of their top 10 teams, right? And this is a major hospital, academic center. So as you can see on these bar graphs of number of reports on the x-axis, you can see that number 1 is the type of the omissions, right, that we're doing, and 15 of those, as you can see, were near misses, right? So we're catching things. That's good. But a lot of those actually reaching the patient, right? So omission errors are number 1. You can see kind of going down, extra dose, barcode scanning. It's interesting if you think about the barcode scanning. Yes, we have near misses because that technology has advanced a lot, right? So we're not harming people anymore. There's still human error, but because of the wristband and the scanner and all these things, with those errors no more reaching the patient, which is great. We cannot eliminate human error, right? Human error will happen. I forget my keys when I go to work. I forget something. There will be human error. That's just the nature of who we are. However, I think the goal is to eliminate patient harm, right? That should be our way of thinking, using the technology. So with this in mind, got the first grant from the Center of Innovation, and we created a lab. So this was actually called a mold room in radiation oncology, one big skinny room. I like to think about it like a garage startup. And we got some computers there, and we got some eye tracking and cameras and some EEG equipment. And we say, well, let's go to work. Let's start bringing physicians here, and let's ask them to do this work, and we're going to start measuring what's going on, right? And get some clicks again, and all these great data. So we started there, and we've done some good work, published some papers, and went to some conferences, and it's led that now we are fortunate that we have a kind of more setup lab. So we can see at the top is kind of participants room. There's a one-way mirror between the rooms. You have a researcher station. So now we are removed from there. So we can set up a study. We can communicate with the participants what we want them to do. They can sit down, work on with the EHR, with the device. We can observe them, but they have their space, and we can do a really nice set of studies. So that's what we've been engaged in. Prithima will share some of the exact work we've been doing. So overall, just to kind of wrap up and put it to for Prithima, it seems to us that there's so many challenges remaining after running this in multiple EMRs that we've run the studies, worked with many physicians by now. The last study we had 40 residents coming, each on 2 sessions, 80 hours of data collection on just that last project. Right, and analyzing all these interactions at the very granular level, at the click level. And we really think that the challenges remain, and Prithima shows some, there's a lot of things that we can be optimizing. Overall, our results are definitely consistent with research and theories related to cognitive information processing. So as we're gonna have an experiment, we say we'll give you a high volume of results versus low volume. We beautifully see here, your performance degrades, but the more we kind of throw at you, all these relationships that would be claimed by theory, we can now see them happening in the lab as we quantify them. Additional work is needed. So for all of us, we just discussed before we started, what can we do instead of having one lab, one participant, one researcher? There's tremendous opportunities that I think we could have with students and residents and everybody else. All work is happening in EHRs. If we can capture this, think about the speed of how we could maybe informing what usability, what workflows are better, right? In a quantitative form, not just kind of an expert claiming that we have something. So that's fascinating. And of course, I don't want to kind of discard that all of this has to be done on EHRs. There's work to be done on, going out there, making sure people are communicating, right? People are having the right workflows. So a lot of kind of quality improvement and process improvement work. There's tons of work in the hospital that remains on that end as well. So with this in mind, I'll just ask Prithima to come up and show you guys some specifically talk about 2 studies.
Thank you. All right, so I'm going to now focus down to our research study and our findings from our research studies. The first one I'm going to talk about is the first paper that we published in JAMIA, that is towards better understanding of task demand workload performance during physician interaction with EHRs. The underlying concept, or I should say the central concept of our research, is to better understand the interaction between the physician and the EHR here. So we use various different terms, and don't get panicked with all these words, but these are required to understand what we are trying to do in our research. So we first define any clinical tasks that are task demands. So it could be increasing task demand and decreasing task demands, and these are determined by the goals that you need to achieve by means of task performance. So say, for instance, you are required, you were asked to go from point A to point B, and that is your task. So that is independent of the user, and it depends upon how you perform the task. So we'll come back there. Task complexity is a property of the task, is what we define here. So say, for instance, if the point A to point B is in a rural environment, so you are either driving in a rural environment or in a downtown New York or sometimes. So that's a task property, is what we define here. Next comes the effort, which is mental effort, cognitive effort, And it is the individual perception or individual reaction to the task demand here. So it depends upon the knowledge, the age, experience, gender, so on and so forth. And the last one is the task difficulty, which is the interaction, the actual interaction between the task and the individual. So it basically is related to the processing effort, which is the processing of your mental effort that is required by the individual to perform the task. And it is dependent on the context, state, the capacity of the individual, and strategies used to attain the task here. So when we say that increase in task demand increases workload and thus degrades performance, the relationship is not that linear. But there is the strategies that might affect your workload, how you manage your workload, and thus that affects the performance. So the first task here is we simulated 3 clinical scenarios in Epic Playground. The first one is the pneumonia scenario, and we gave these 5 set of tasks to be performed for the pneumonia. Second scenario, the UTI, which is the urinary tract infection. Second was the pneumonia, which has 8 subtasks, and the last one was the heart failure, which has close to 9 subtasks. So these were given to the participant. And we had 17 residents coming into the lab, and they performed all the tasks that were given. We quantified task demand based upon the user behavior. That's number of clicks that they had performed in order to achieve the goals, and the time to complete each of those scenarios. At the end of each scenario, we collected perceived workload scores, which we use a very validated and very most widely used NASA TLEX index. And this is a scale where participant will be asked to mark on 6 different dimensions, and at the end we also take the weighted scores of that. And we quantified performance based upon the severity of each and every omission error. So we know the sub-goals that each participant has to achieve, and any tasks that were missed, we would associate, or we would determine the severity of that omission error. So we quantified that, and we had clinicians, expert clinicians on our team. They defined the severity score in the study. So table here gives descriptives of all the measures that we looked at. The task demand, we looked at total number of clicks, and further we divided those total number of clicks into navigation clicks, decision clicks, and search clicks. The NASA TLEX score and the performance, and which is measured based on time to complete the task, number of participants omitted any of the subtasks, and the severity associated with that. And each row defines the 3 clinical scenarios that we used. So you see there is a much variability, especially for the last 2 scenarios, pneumonia and heart failure. So when we quantified task demand, we found that pneumonia, as measured on total number of clicks as well as time to complete the task, seems to be very demanding compared to the UTI or the heart failure case. When we looked at the relationship between, so how this task demand affect the workload and performance, we did not see any significant effect on workload, but we definitely saw that increase in task demand decreases performance. And the task demand was related to workload, which was close to significant 0.04 level, but increase in task demand, especially for the pneumonia case, you would see the NASA TLEX is 51, was significantly higher compared to UTI and heart failure. And the performance here, you would also see that the pneumonia case, the range of the severity was 1 to 4 compared to UTI and the heart failure. So basically the take-home point here is task demands do affect performance, workload and performance. And interestingly, this was first of a kind of our study where we quantified the performance, where we quantified the behavior in terms of task demand, and also quantified workload, looked at the relation between these 3, and we had this published in the journal paper. However, we think that the behavior data in terms of clicks could definitely be used in terms of measuring, or it's like a quality metrics to see how good the EMRs are designed, or how better a physician has been trained, so that we could make improvements based upon that. So behavior data seems to be more relevant in this case. So we kind of did a follow-up analysis in our next paper where we really looked at the behavior approach here. So now in this study, this is our second study where we looked at task demand, also mental effort, and we measured mental effort because it is everything in brain, so we use physiological measures to quantify our mental effort. Task difficulty, again, was quantified based on behavior, and this time click behavior. So it's not number of clicks, but what is the click patterns that people use that could determine performance here. And we also looked at the task flow, how which route. So if you go into Epic or in any any web search engine, you have many different ways to get to your destination. So in Epic, we have different task flows that physicians take to get to their final performance level. So we looked at the deviation of these task flows. And finally, we measured performance in two different types of omission errors. One is unconscious omission errors. So as physicians go through so quickly, they tend to miss few things, or they incorrectly checks one thing versus the other. That's unconscious omission error. And the second one is you also see that people trying to achieve the task, however, they fail to get to what they want and they let it go. In real situations, it would either delegate it to the nurse or somebody else to do the task, because physicians cannot find what they're looking for. So again, it's a follow-up of the previous study. So we had three clinical scenarios, and this time we quantified task demand based upon the clinical demand itself. So it's quantified by the physician, and as per the clinical essence of that, UTI was the least demanding compared to pneumonia and heart failure in this case. And we used eye tracker to quantify our mental effort. We looked at the changes in pupillary dilations. We also looked at blink frequency and the gaze speed, how quickly physicians were interacting with the Epic system. Task difficulty, as I mentioned, we looked at the click patterns and task flow. So click patterns, we collaborated with Brown University, so they used some calculations behind the scene, and they have this they came up with two levels of filtering techniques that they looked at, and they figured out what are the most prominent click patterns, which I would go in detail in the next slide, but they came up with different click patterns that would be shown by the user. And we also looked at task flow in terms of deviation. So these are the two performance levels in terms of omission error. One is omission error with no evidence of trying the task. That means it's an unconscious slip or omitting the task. And the second one is omission error with evidence of trying. So they were struggling to get to the task, but unable to perform the task. And the slide here gives the descriptive stats of all the measures that we looked at. I want to focus on the second set of columns where it says task difficulty. These were the significant click patterns that we looked at. One is DID. So D is decision click, I is input click, and with a superscript of M indicates it's a multiple input clicks, and followed by another decision clicks. And especially you would see these kind of patterns when physicians were editing order details. So DIMD was editing order details, and we have the second significant pattern was navigation, decision, and multiple navigation that were prominent in making orders. When they get into their order sets, they start making these orders. We saw those patterns there. And reviewing or exploration of orders, we also saw like navigation, decision, then followed by multiple navigation. The last one is search for orders, and this is where we saw navigation input and multiple decisions. So these were pretty significant patterns that came out from the analysis. We also have, descriptives for all the three scenarios: UTI, pneumonia, and heart failure. When we looked at the relationship between, it's a one-on-one relation, so we tested the task demand with each and every other component. So first, what we find is task demand was significant or negatively affecting the blink frequency. That's what you would expect if you are interacting with the system. With a lot of visual information that you are perceiving, you tend to blink less, and that's what we saw. The higher the task demand, the lower the blink frequency was. For the task demand and task difficulty, we saw that people did show some click patterns, especially some significant click patterns. The searching for orders was the one that came to be significant of all type compared to all other type of click patterns with increase in task demand. So increase in task demand, people tend to do more of search for orders instead of going through template-wise procedure. So instead they were using more search terms to get to the order that they were supposed to prescribe for that condition. And we also had found the mental effort was significantly related with task difficulty. Blink frequency was significant, as well as task-evoked pupillary responses were also significant with these click patterns, especially searching for orders here. So what we did is now we looked at the relationship, all the task components as well as mental effort with performance here. Again, this table gives you a description of different types of errors in column-wise: no error, omission error, with no evidence of trying, and omission error with evidence of trying, with the different components here. And what we found is task demands were positively related with omission errors. So you would see in pneumonia case, pneumonia was the highest. So because it was considered as the highest, more in task demand, we found that people made more omission errors because pneumonia case had more labs or orders that they were supposed to make. And the way the EPIC was designed, it was easy to skip one or the other medications or the orders in this case. And we also found that pneumonia was also significant for omission error with evidence of trying. So people were trying to look for the orders, however, they were failing, and that's why they're giving up. And we also found the mental efforts of people experiencing, whether that is due to clinical experience or experience with interaction with EHR. People who were experiencing more mental effort also had degraded performance, and blink frequency and task-evoked pupillary responses were the one that came to be significant here. And finally, task difficulty, the special click behavior was significant, which is searching for orders, was significant for both omission error with evidence and with no evidence of trying here. So what we did is we tried to zoom into the behavior. So what is going on that is making the task difficulty to be significant here, and also the other way around, how it was increasing the mental effort. So when we reanalyzed the videos, we looked at the videos, we found two different ways or different behavior of these users when they were interacting with the EPIC system. So few of the users, they followed certain templates. So they are very much trained to use EPIC system. So based upon the clinical scenario, they know which process to follow. So for pneumonia and heart failure case, they were supposed to first admit the patient, then access order sets after they admit the patient. In the second, the type of users where they were not following the training that they got, but they were simply following the task that we asked them to perform instead. So instead of admitting the patient into a medical wing, they were directly going and searching for orders, and that that is the reason why they were unable to get the order that they were looking for. However, the other type, people who were using the templated version, they were getting the orders, but they were going so quickly that they were showing more of unconscious omission errors, because they're trained, they're fast, they're not paying attention what they're checking, they're going check, check, check. The second one is they are really trying hard, because now it is again the search type and how the search engine was designed. If a patient is admitted through a certain admission, a medical wing, you would be then able to see the medication list that are pertaining to that medical wing. So they were, it won't list out the medication list or the order list if you go the other way around on non-templated version. So this we found little interesting, and the reason why the residents who were following non-templated version, they showed this NID is the click pattern, that's navigation input and multiple decisions, because they were repeatedly doing that to search for orders and they were not getting it, so canceling the search results, then again redoing that. So we found this particular click pattern to be more significant for participants who were following non-templated version. So again, our conclusions from this study is that task demand do affect mental effort, task difficulty, as well as performance. But we think that task difficulty, which is based on user behavior, could be quantified and can be used as a quality assurance, models, or we could build some models, get somebody for training, and you would get feedback as soon as they are done with the scenario, show them how they have performed based on their behavior, their task flows, and then we could determine whether the person needs more training, or the EHRs need to be redesigned because this is something complex, or something of that sort. And finally, the behavior, even tracking the physiological measures. So since we use remote eye tracker that is mounted on the screen, so that is very easily accessible and can be mounted on any other screens. So even tracking the live physiological metrics would also be helpful, both in terms of training as well as improving the EHR design. Let take over.
Great. I'm going to change out the slide deck. If everybody wants to.
This one was, the same VT, the low VT and high VT. High VT is available in the search results when you go through a templated version. If you search for the same order before going to the templated version, it just gives you the low VT option. So either they end up choosing low VT because they don't see high VT on the screen, or they just give up. So these were the more significant errors that we saw in our scenario.